What do you do for the anxiety that occurs? That might require a different class of agents too.
Yeah, so in summary, for breakthrough, we think about our D2 antagonists, we think about steroids, but if we think anxiety is a big component, of course, we use our benzodiazepines. Mm-hmm. And my benzodiazepine of choice is lorazepam, just because it has fewer active metabolites and is typically better tolerated. But I think something that we really need to highlight here is that so much of our data has been on prophylaxis. And if you actually look at how many studies have been on breakthrough or even defined what refractory is, it's largely missing. I think Rudy Navarre had a study looking at metoclopramide versus olanzapine in the breakthrough setting. But when I'm even looking up definitions of what refractory is, I think NCCN just came out with something to even define refractory. And does that mean you have failed prophylactic guidelines and breakthrough, and then you have, or what does that mean? Yeah. Another way of maybe terming that seems a little easier is just to call it chronic CINV. So despite everything, and we as palliative care oncologists, I think of all the different receptors, and I try to think of what can I reverse. But there's situations where people have GVHD and they're infected and they're on a bunch of medications, and despite me thinking about it and trying to target all those receptors, it just exists and it's just there. So how do we treat in that setting?
So I think it's worth pointing out to your that there are other causes of nausea that may not be related to the drugs and specifically to the chemotherapy that occurred. Mm-hmm. So gastroparesis, brain metastases. So our audience should think that if you have this chronic, what looks like CINV, it may not be. It may be a completely different etiologic, physiologic reason.
Definitely broadening your differential. I mean, I've diagnosed patients with leptomeningeal disease, brain mets, and this is after many people had seen them, and I had to take a big step back and say, okay, what else am I missing here? The story doesn't add up.
I've gotten burned a couple of times on renal insufficiency. For someone who just comes in feeling lousy and nauseated all the time. We thought it was CINV, and then of course we get laboratories frequently, but sometimes you get surprised. So not to think in the box like anything in medicine, right?
And other medications too.
Right, and definitely other medications in interaction.
Or opiates rather, and other pain medicine, antimicrobials, all those certainly have their own incidence of CIN or of nausea and vomiting. So you can't forget about those. And oftentimes, I know sometimes we put blinders on, but you can't overlook those because oftentimes changing those medications actually solves the problem.
So what I'm doing now is after I've thought about it and I've excluded all these things and they still have those symptoms, my drug of choice right now, my approach is olanzapine. And for those that don't know what olanzapine is an antipsychotic that we typically at much higher doses have used to treat bipolar disorder and alike. And the reason why it works, and my fellows tend to remember this, is I tell them it's promiscuous. And it's promiscuous in that it hits multiple dopamine receptors and multiple serotonin receptors. And there's something about that that we don't quite understand, in the same way that we have our dirty TKIs like sorafenib that hit a bunch of receptors and maybe aren't as clean as we like them to be.
So maybe it's better not to be clean, particularly with CINV. It's an interaction of multiple pathways, right?
Absolutely, and maybe in the setting where this chronic or refractory nausea continues, there's something about hitting multiple receptors that maybe that's why it works. The doses, of course, are much lower, and Dr. Navarre did most of the studies in this, uses 10 milligrams. It's the convenience of once a day dosing. We usually do it at night, which causes a little bit of sedation, which actually patients frequently like. And then you continue it either 4 to 5 days thereafter. In palliative care, we've been using the olanzapine for nausea independent of chemotherapy. And dosing in that setting actually has wide variation, anywhere from 2.5 milligrams up to 10 milligrams. And that's because some of us worry about the sedation caused by the higher dose. But in my experience, the sedation is really the worst after the second day of olanzapine and often gets better thereafter. So I don't know what anyone else has any experience with using olanzapine, but it, again, to Charles' point about cost, it's pennies as a generic in comparison to some of these other drugs.
Yeah, it's a very old drug. Do you have experience using it?
So yes, and I was involved with Rudy Navari, and he presented a paper at the ASCO MASC Palliative Care Conference last fall, looking at the common 3-drug regimen for highly metagenic chemotherapy, steroid, 5-HT3, and NK1, and then randomized to olanzapine or placebo on top of that. And it improved the no nausea by about 15 to 20 percentage points for the whole 5-day period of time, and the complete response aspect of that too. And interesting, like what you said, that there was an increase in drowsiness on day 2, but it got better after that. So that is, and there are other studies that have looked at it instead of the NK1 receptor antagonist, which look promising. There's one other drug that we haven't talked about that a lot of people don't know about, and it's similar to olanzapine, which also stimulates appetite and causes weight gain, which can be problematic and cause diabetic metabolic syndrome sort of thing, but it can be helpful in patients with cancer who need to lose that, who gaining some weight is not bad.
Right.
But magistral acetate also decreases nausea and vomiting. And we first noted that when we were looking at nausea and vomiting as a side effect of the potential side effect for our early anorexia cachexia studies. We asked the patients a month later if they were having nausea from this drug, and the placebo group said 40% were having nausea, and 15% of the magistral acetate group said they were having nausea from it. Vomiting was 24% versus 8%, a 2/3 reduction. When we ended up publishing that, we said, well, maybe it's because they were getting lactose, but the amount of lactose they get is what you get in 1/3 of 1 ounce of milk per day, so that wasn't it. And we proposed it was because of the advanced cancer, a lot of nausea and vomiting. And subsequent studies have actually demonstrated that it does decrease nausea and vomiting in advanced cancer. And also a study has actually been done in patients getting chemotherapy, where it also decreases nausea and vomiting. So something to think about occasionally in that, more often in the non-chemotherapy nausea and vomiting setting.